This is JAPI, and welcome to JAPI Podcasts.
JAPI Podcast. I am Dr. Chandni R from JAPI Editorial Board. Welcome to the JAPI Podcast of the February 2025 of JAPI, Volume 73, Issue 3. This issue of JAPI has some really interesting articles, including 8 original articles, 4 review articles, 1 point of view, 7 unique case reports, 1 pictorial CME, and 2 letters of correspondence. Let us discuss this in detail. From the original articles, the first article is titled Sample Size Calculation for Paired T-Tests Using P-Value and Confidence Intervals When Standard Deviation of Difference is Not Given by Shyam Vyeth et al. Sample size calculation is an important step for carrying out any research. Most of the sample size estimating utilities applications use the standard deviation of differences in their formula for paired design, which usually is not reported in the published articles. Researchers are left to use the pooled standard deviation SDP instead of using the standard deviation of differences. The standard deviation of differences gives a more accurate estimate of sample size for a paired design. The standard deviation of differences can be determined from the p-value or confidence intervals, which are usually reported in the published articles. In this paper, authors describe and illustrate with an example how to determine sample size from the p-value or confidence intervals. I encourage all our readers and researchers to go through this article. The next article is titled Spectrum of Clinical Manifestations in Patients of Scleroderma and its Correlation between Cutaneous and Pulmonary Involvement by Jyotsna Walk et al. This article describes the range of signs and symptoms observed in scleroderma patients and the potential correlations between pulmonary and cutaneous involvement. 104 patients were evaluated by standard diagnostic investigations like CBC, ESR, LFT, RFT, ECG, HRCT, and PFT. The modified Rodnan skin score MRSS was used to assess skin involvement. Results: 71% patients had diffuse cutaneous systemic scleroderma, while 28% patients had limited cutaneous scleroderma. 92% patients had Raynaud's phenomenon, 65% patients had mild RSS and mild MRSS, while 25% and 10% patients had moderate and severe modified Rodnan skin score or MRSS respectively. Skin tightening 88%, sclerodactyly 88% were the most common cutaneous manifestations, followed by digital ulcers and pits in 58%, diffuse edema of hands and feet in 38%, salt and pepper skin 38%, calcinosis 31%, telangiectasia 25%, contractures 19%. Pulmonary manifestations showed interstitial lung disease in 60% patients and pulmonary hypertension in 14% of patients. 8% patient had ILD with pulmonary hypertension. 46% and 17% patients with diffuse cutaneous systemic scleroderma had mild and moderate MRSS respectively, while 8% patient had severe MRSS score. About 19% and 8% patients with limited cutaneous systemic scleroderma had mild and moderate MRSS respectively, while 2% patients had severe MRSS. There was no significant correlation of MRSS and subtypes of scleroderma patients. The mean MRSS score in ILD was low in comparison to the MRSS score in patients with pulmonary hypertension. There was a significant correlation of MRSS and pulmonary involvement as indicated by the student's t-test p less than 0.05. Conclusions: in systemic sclerosis patients, the emergence of severe systemic complications such as pulmonary arterial hypertension and interstitial lung disease can manifest regardless of disease duration or subtype. Symptoms might not consistently align with disease advancement. Therefore, a thorough evaluation incorporating symptoms and specialized diagnostic tests such as pulmonary function tests, echocardiography, and HRCT is crucial for early identification, timely treatment, and better prognosis. The MRSS serves as a valuable clinical instrument for monitoring scleroderma progression. Fourth article is survival and clinical outcomes after single vessel percutaneous coronary intervention using drug-eluting stent, an observation and follow-up study in a tertiary care center in the Gangetic Plains of North India by Soumik Ghosh et al. Long-term survival data following PCI in North Indian populations are limited. This observational study aimed to evaluate survival and clinical outcomes after PCI with DES and identify factors associated with mortality and adverse events such as chest pain, dyspnea, and bleeding. The study included 1,112 adult patients undergoing single vessel PCI with drug-eluting stent. Patients were followed up for 18 months via outpatient assessments and telephonic interviews to assess survival, chest pain, dyspnea, and bleeding. After 18 months of follow-up, of the 782 patients, 740, 94.62% were alive and 42, that is 5.38% had died. Significant factors associated with mortality included older age, history of hospitalization, chest pain, dyspnea, and bleeding. Acute coronary syndrome was the leading cause of death, 52.3%, followed by post-PCI complications. Conclusions were PCI with DES, that is drug-eluting stent, demonstrated a high survival rate in North Indian patients with single vessel disease. Key predictors of mortality were age, history of hospitalization, and post-PCI symptoms, emphasizing the need for long-term follow-up and aggressive management of symptoms to improve outcomes. The next article is titled A Clinico-Radiological and Bacteriological Profile of Community-Acquired Pneumonia in a Tertiary Care Center in Eastern India by Vishwajit Haiti et al. The aim of this study was to evaluate the clinico-radiological and bacteriological profile of community-acquired pneumonia (CAP) among patients admitted to a tertiary care hospital with special reference to CURB65 score and acute inflammatory markers. This observational cross-section study, conducted over a period of 18 months in the Department of Respiratory Medicine in a tertiary care hospital in India. Patients with features of lower respiratory infection of all age group and gender were included in the study. Immunocompromised patients, pregnant patients, patients with malignancy, active tuberculosis, and those who received antibiotics in previous 90 days or were admitted to any other healthcare facility were excluded from the study. Research, a total of 100 patients with male predominant, 63%, an average age of 47.6 plus or minus 1.78 years, 33% current smokers, and diabetes 27%, hypertension 19% as comorbid conditions were included in the study. Klebsiella and Pseudomonas species were among the most common isolates, closely followed by Streptococcus pneumoniae among the elderly population, whereas Streptococcus pneumoniae was the most common organism overall and 48% showed no culture isolate. Conclusion, it's an absolute necessity to conduct several similar studies in the future among different patient demographics, localities, and practice settings, keeping in consideration the constantly changing microbiological profile over time and the introduction of new diagnostic and management modalities. The next article is an interesting one on the role of meditation as adjuvant therapy on gastrointestinal quality of life among individuals with functional dyspepsia in an outpatient setting. A randomized pilot trial by Monica Patania et al. Functional dyspepsia is one of the most common reasons for Medicare visits. This study aimed to assess the effectiveness of meditation as an adjuvant to the standard treatment in individuals diagnosed with FD. that is functional dyspepsia. This study assessed the role of meditation as an adjuvant therapy in patients with functional dyspepsia and compared it with the control arm receiving standard treatment alone. The primary objective was the change in the gastrointestinal quality of life index GIQLI score, and the secondary objective was to assess the changes in the hospital anxiety and depression scale HADS score and Pittsburgh Sleep Quality Index PSQI score before and after the intervention. Methods. Patients fulfilling the inclusion criteria were divided equally into two arms, experimental and control groups. The experimental group received the standard treatment for dyspepsia, that is PPI, domperidone, TCAs, and Vaishwanara Agni meditation, VAM, while the control group received standard treatment alone. Both groups were compared at weeks 0, 4, and 88 in terms of change in GIQLI, HADS-A, HADS-D scores, and PSQI score results. This study showed that both groups experienced significant changes in these scores at 4 and 8 weeks when compared with the baseline time point. However, when both groups were directly compared, it was observed that the experimental group exhibited notable variations in the GIQLI and the HADS-D score after 8 weeks and PSQI score after 4 weeks when contrasted with the control group. The differences were found to be statistically significant. Conclusion: this pilot randomized controlled trial investigated the impact of meditation as adjuvant therapy for FD, revealing improvements in GI health, mental well-being, and sleep quality compared to standard treatment alone. This study recommends incorporating meditation into the management of FD and similar conditions, highlighting its holistic nature that address not only specific symptoms but also overall well-being. The next original article is titled Clinical Phenotypes and Disease-Specific Health-Related Quality of Life in Patients of Chronic Obstructive Pulmonary Disease by Rahul Verma et al. A hospital-based cohort study was conducted among COPD patients of varying phenotypes. All patients were evaluated through a detailed history, clinical examination, complete blood count, and ECG to fulfill the inclusion and exclusion criteria and categorized into different phenotypes: non-smoker, non-exacerbator phenotype NEP, exacerbator phenotype EP, and asthma COPD overlap ACO. Following this, the participants were evaluated based on the modified Medical Research Council dyspnea scale and COPD assessment test score to assess HRQOL at the beginning and after 3 months of standard treatment. Results: among the 100 participants, the average age of the participants was 58 plus or minus 6.8 years, while male predominance was 62%. There was a significant difference in the CAT score and MMRC. Among the study groups, the CAT score was worst in the ACO group, 23%, with partial improvement, that is 14.26% after 3 months of treatment, still being relatively lower than in other groups. Conclusions: patient with ACO, that is asthma COPD overlap, had significantly poorer HRQOL compared to those with NEP, EP, and non-smokers group. Hence, patients with asthma COPD overlap group, NEP, and EP should be offered different treatment approaches, focusing on the components that exacerbated the symptoms. The next research article is titled Clinical Spectrum and Therapeutic Outcome of Myasthenia Gravis in a Tertiary Care Hospital, a Retrospective Study by Sujaya Raghavendra et al. The study aimed to analyze the clinical spectrum and therapeutic outcomes of myasthenia gravis in a tertiary care hospital from India. A retrospective study was conducted using records of myasthenia gravis patients from Madras Medical College, Chennai between 2021 and 2023. Data from 49 myasthenia gravis patients were assessed, including demographic, clinical characteristics, treatments, and outcomes. The male to female ratio was 1.33:1, with a mean age of diagnosis of 43.6 years. Generalized myasthenia gravis was more common, 83.6%, while ocular MG accounted for 16.3% of cases. The most common symptoms were ptosis and diplopia, 90%, followed by bulbar symptoms, 60%, and respiratory illness, 19%. Myasthenia crisis occurred in 14 patients requiring intensive care. Thymoma was identified in 9 patients and 7 underwent thymectomy, which appeared to reduce crisis risk. Bedside tests showed a decremental response to repetitive nerve stimulation, 93.8%, and acetylcholine receptor antibody positivity in 45% of cases. Treatment strategies include acetylcholine esterase inhibitors, 63%, intravenous immunoglobulin, 11%, and plasmapheresis, 3.5% for severe cases. Combination therapy with immunomodulators ensured better symptom control and reduced crisis incidence. Rituximab was effective in patients resistant to plasmapheresis or intravenous immunoglobulin therapy. The median hospital stay was 14 days with a range of from 6 to 61 days. Mortality was recorded in 4 cases, while 92% of patients had stable vitals at discharge. Common comorbidities included diabetes, 20%, hypertension 22%, and hypothyroidism 10%. Complications such as aspiration, pneumonitis, and sepsis were observed in a few cases. The study highlights the importance of early detection and a multidisciplinary approach to managing myasthenia gravis effectively. Further, large-scale studies are necessary to refine treatment strategies and improve patient outcomes. The findings provide a valuable reference for future MG research and treatment protocols in India. The next original article is titled "To Assess Prevalence of Thyroid Dysfunction in Patients with Heart Failure and Impact on its Prognosis" by Anubha Srivastava et al. This study, conducted between 21st July 2021 and 20th July 2022, was done to evaluate the prevalence of thyroid dysfunction in patients with heart failure and its impact on prognosis, specifically regarding hospital stay duration. Amongst the 180 patients included in the study, thyroid disorders were seen in 28.6% of patients, with 6.5% having hypothyroidism and 22% hypothyroidism. Thyroid disorders were significantly associated with higher NYHA class 3-4, serum urea, serum creatinine, and lower hemoglobin levels. However, age, gender, or BNP levels were not significantly associated with thyroid disorders. There was no significant difference in heart failure patients' length of hospital stay with or without hypothyroidism. 6.5% of heart failure patients died during the course of the study, but this was not statistically significant. Conclusion: thyroid disorders were highly prevalent among heart failure patients and have a significant clinical impact on their prognosis. Patients with thyroid disorders exhibited anemia, higher NYHA class, greater renal dysfunction, and longer hospital stay. Clinicians should consider screening heart failure patients for thyroid dysfunction to improve patient outcomes, and more studies are needed in this field. Now we move on to the review articles. The first review article is Management of Vasodilatory Shock, a concise review by Utkarsh Shah et al. Vasodilatory shock is a severe circulatory disorder characterized by excessive vasodilation leading to impaired tissue perfusion and organ dysfunction. This review explores its pathophysiology, clinical implications, and management strategies. Key points: pathophysiology: vasodilatory shock results from impaired vascular response to catecholamines, excessive nitric oxide production, and metabolic disturbances. Microcirculatory abnormalities cause heterogeneous blood flow, leading to oxygen delivery issues. Hemodynamic changes: initially, cardiac output increases to compensate for low systemic vascular resistance. If untreated, the condition progresses to hypotension and multi-organ dysfunction. Management strategies include fluid resuscitation. Balanced crystalloids are preferred over colloids due to better safety profiles. Fluid administration should be individualized. Vasoactive agents: catecholamines like norepinephrine are the first-line vasopressors with vasopressin and epinephrine as adjuncts. Newer agents, angiotensin II and V1A selective agonists like celepressin, show promise in refractory cases. Adjunctive therapies like methylene blue and hydroxycobalamin, potential alternatives for vasodilatory shock resistance to conventional vasopressors. Extracorporeal membrane oxygenation ECMO may support circulation in refractory cases. Corticosteroids may help in reversing shock in some patients but require careful selection. Vitamin C, the recent studies show no significant mortality benefit with vitamin C. Conclusions include, despite advancements, vasodilatory shock remains a challenge with high mortality. A multimodal approach combining fluid therapy, vasopressors, and emerging treatment is essential for improving outcomes. Further randomized trials are needed to validate newer therapeutic strategies. The review provides a concise yet comprehensive guide for clinicians managing vasodilatory shock in critical care settings. The next review article is Kidney and Lungs, Do They Crosstalk? By Sanchit Mohan et al. The kidneys have a wide variety of functions, including maintaining fluid electrolyte and acid-base balance, and also the regulation of blood pressure done by the RAS system, and the secretion of hormones including erythropoietin, renin, and 1,25-dihydroxy vitamin D. Lungs provide oxygen to tissues and exhale carbon dioxide from the body. Metabolic acidosis is compensated by hyperventilation, leading to the washout of carbon dioxide and restoring pH to near normal. Renal to pulmonary pathways. Lung involvement is not an uncommon finding in patients with kidney disease. Those who died with azotemia and pulmonary edema were found to have, in autopsy, alveolar wall thickening and fibrinous alveolitis with various stages of hyalinization of the intra-alveolar exudate and the hyaline membrane lining of alveoli. Fluid accumulation in alveoli in AKI is not only due to an overall positive fluid balance, rather with multiple mechanisms including the inflammatory pathway which leads to increased microvascular permeability. Acute kidney injury can cause lung injury through increased vascular permeability, inflammatory reactions, and oxidative stress. Chronic pulmonary fluid accumulation is often found in patients with CKD, leading to myofibroblast proliferation and extracellular matrix deposition, causing the thickening of the alveolar capillary barrier. Although this process is initially protective and prevents pulmonary edema, it eventually becomes maladaptive, leading to restrictive lung physiology. The role of the kidney is to balance nitrogenous waste, fluid status, and acid-base balance, and in the presence of AKI, these functions compromise lung functions. When we look at pulmonary to renal pathways, pulmonary diseases can also affect renal functions in many ways. Acute lung injury causes hypoxemia, which lead to organ dysfunction, including AKI. Direct effects of hypoxemia on the renal blood flow as well as inflammatory mediators released due to hypoxemia can be potential mechanisms of AKI in patients with ARDS. The inflammatory mediators released in the bloodstream due to acute lung injury can amplify neutrophil activity by producing proteases, reactive oxygen products, platelet activating factors, and leukotrienes, thus worsening inflammatory status and leading to multi-organ failure, predominantly affecting kidney functions. Hence, ALI and ARDS can lead to AKI and mortality by itself. Inflammation and immune responses. Cytokines and chemokines such as IL-6, IL-1, and macrophage inflammatory protein 2 play a major role in initiating and progressing renal and pulmonary impairment. It was noticed that the administration of the anti-inflammatory cytokine IL-10 reduced pulmonary markers of injury and inflammation. Conclusions. In conclusion, the intricate crosstalk between the kidneys and lungs is far from a one-way street. Lung disorders can provoke renal injury, Conversely, kidney dysfunction can impact pulmonary health. In many disease scenarios such as sepsis, heart failure, and systemic autoimmune diseases, both the lungs and kidneys can be simultaneously affected. Recognizing and addressing this multi-system involvement is paramount. The complex interplay between these two vital organs challenges healthcare professionals to adopt a multidisciplinary approach to patient care. Nephrologists and pulmonologists must collaborate closely to devise treatment strategies that consider the holistic well being of the patient. The next review article is titled Biologics and Tuberculosis Preventive Therapy by Alok G. Ghoshal et al. The most common side effect associated with biologics is an increased susceptibility to infections, a heightened risk of tuberculosis reactivation in patients with latent tuberculosis infection. LTBI, latent tuberculosis infection, has been observed for anti-tumor necrosis factor agents as well as non-anti-TNF targeted biologics. Guidelines for programmatic management of tuberculosis preventive therapy in India, PMTPT, mandate TB screening and treatment for patients on immunosuppressive therapy and anti-TNF treatment. Guidelines for programmatic management of tuberculosis preventive therapy in India, PMTPT, advocates a nationwide phased implementation of tuberculosis preventive therapy with prioritization of high-risk groups, people living with HIV plus antiretroviral therapy or ART, household contacts of pulmonary tuberculosis patients. The expanded target population now includes those on immunosuppressive therapy, having silicosis, on anti-tumor necrosis factor treatment, on dialysis, preparing for organ or hematologic transplantation. One of the concerns commonly expressed about the large-scale use of tuberculosis preventive therapy (TPT) is the potential risk of propagating drug resistance. These concerns have not been supported by high-quality evidence to date. The current recommended and available tests for assessing TB infection are the tuberculin skin test (TST) and interferon gamma release assay (IGRA). Low sensitivity is found both in TST and IGRA among very young children. Increasing the sensitivity of LTBI screening. Low sensitivity is found both in TST and IGRA among very young children. Increasing the sensitivity of latent tuberculosis infection screening by combining IGRA and TST is not recommended by PMTPT. But studies have shown that dual testing with both TST and IGRA may reduce the possibility and the probability of false negative results in the presence of severe immunosuppression. JAK inhibitor baricitinib, tofacitinib, IL-6 receptor blocker tocilizumab, IL-1 receptor antagonist anakinra, anti-CD20 rituximab, biologics in asthma omalizumab, mepolizumab, benralizumab do not increase the risk of tuberculosis, while TNF-alpha receptor blockers like etanercept increase the risk. The main challenges are patients with rheumatoid arthritis may have impaired cell-mediated immunity and false negative TST or IGRA, regardless of the presence of immunosuppressive medications. Patients on TNF-alpha blockade are often on steroids or methotrexate, which may result in false negative TST or IGRA. How to manage tuberculosis infection before considering biologic therapy? When TB infection is diagnosed before biologic therapy, latent TB infection treatment should be completed before commencing biologic therapy. If there is a pressing clinical need to start biologics, it can be started at least 1 month after starting tuberculosis preventive therapy. What should be done when patients develop tuberculosis disease while on biologic therapy? When such a situation occurs, the biologics should be stopped and a full course of anti-TB treatment should be initiated. The biologics can be resumed at least 1 to 2 months after starting anti-TB therapy or after completion of TB treatment. Conclusion: as the benefits of prophylaxis are more than the adverse effects, the patient should be treated with INH prophylaxis. Any suspicion of inadequate treatment earlier should prompt initiation of TPT before commencing biologics. Patients with high risk of tuberculosis reinfection while on biologics should be monitored clinically every 3 months and with imaging when indicated. A repeat TST IGRA annually has been advocated for those who are initially negative. Clinicians need to prudently adopt and apply the recommendations prior to the initiation of biologics. Next review article is very interesting: Plastic Pollution and One Health Crisis, a Burning Issue in Environmental Medicine, by Gauranga Santra. Plastics are used widely in various industries, including packaging, medical electronics, construction, and automotive sectors. Due to the restrictions on fossil fuel combustion, companies are shifting investment toward plastic production, leading to increased plastic waste. Improper disposal through landfilling, incineration, or ocean dumping causes significant environmental pollution, particularly harming marine ecosystems. Microplastics pose significant risk to human health and the environment. They serve as breeding grounds for mosquitoes, increasing the spread of diseases like chikungunya and dengue. Microplastics also promote bacterial growth, including leptospira. While their immunological effects are still under study, they may contribute to autoimmune diseases, prolonged chikungunya arthritis, inflammatory bowel disease, osteoporosis, and osteoarthritis. Microplastics have potential carcinogenic effects, contributing to breast, prostate, and testicular cancers through genotoxicity and hormonal disruption. In neurology, microplastics cross the blood-brain barrier, leading to oxidative stress, neurotoxicity, and cognitive decline. They have been linked to neurobehavioral disorders such as Alzheimer's, Parkinson's, depression, attention deficit hyperactivity disorder, and autism. Cardiovascular risk arise from lipid metabolism disturbances and inflammation, increasing atherosclerosis and heart disease risk. Microplastics also disrupt nutrition by contaminating seafood and reducing marine biodiversity. Exposure to microplastics through inhalation, ingestion, and skin contact causes various health issues, including dermatitis, asthma, allergies, and immune dysregulation. They penetrate the placenta, leading to fetal capillary narrowing and potential organ damage. Occupational exposure increases cancer risk, particularly in industries handling vinyl chloride, synthetic textiles, and e-waste. People living near plastic production or waste sites experience higher rates of respiratory diseases, reproductive disorders, and neurodevelopmental issues. Physicians' role and solutions for plastic pollution. What we can do? Physicians should detect plastic-related health hazards, especially in vulnerable populations, particularly women of childbearing age and children, and address the medical field's significant plastic waste. They should advocate for responsible plastic use, reusable medical equipment, safe disposal, and public awareness. Tackling plastic pollution requires banning single-use plastics, adopting sustainable alternatives like jute, bamboo, biodegradable bioplastics, and improving recycling methods. Equitable waste management and global regulations are also essential. The One Health approach is crucial as plastic pollution disrupts ecosystems and human health. Even if plastic use stops, its impact will persist for decades. Urgent action through policies, sustainable practices, and education is needed. We have discussed most of the article in this issue. Thank you for listening to JAPI Podcast.